Welcome back to the Lift Free and Diet Hard podcast. I'm your host, Andrew Coates. Join me along with industry leaders and friends on a quest to get more people through the gym door and eating and living healthier. Join me where evidence meets empathy while rejecting fitness industry fads and extremism. Let's begin. Dr. Austin Baraki, it's an honor to have you on. I had your co-founder in barbell medicine, Dr. Jordan Feigenbaum, on not too long ago. You guys got a book coming out called Signal, What Your Testosterone Levels Are Telling You About Your Health. That's going to be a fun topic. And for anybody who's not overly familiar with you, you're an MD internal medicine physician, and you're a clinical associate professor of medicine at several academic institutions. That's quite the resume.
Yeah, thanks. I appreciate the opportunity. I know, Jordan beat me to the punch being on your podcast. I listened to that episode and enjoyed it. Glad to follow in his footsteps here. So I practice in a variety of settings and have been kind of in this space for a while. Jordan and I have been working together for over a decade now in the kind of the strength training scene, some fitness and health, trying to bring those worlds a little closer together. But my clinical roles, going back a while, have extended mainly between, I do a fair amount of time in the hospital setting in an academic institution where I teach, medical students and residents, junior physicians. We supervise and take care of patients who are sick enough to need to be admitted to the hospital, take care of them and then send them on their way when we get them better, but also do a fair amount of telemedicine in the primary care space, as well as in the weight management space. I've collaborated most recently with Dr. Spencer Nadolski at his telemedicine clinic and the GLP-1 space and things like that. So wear many different hats, do a lot of different things. And then this book, it emerged as a result of a project that I put together, I guess maybe a year and a half-ish ago, kind of like an educational course on the topic of testosterone, because of how I wouldn't say it was a hot topic. It's just a perennial topic. It's always relevant in this space. People are always interested in it, and I wanted to provide some evidence-based material. And so it's kind of continued to evolve from there.
Well, good shout out to Dr. Spencer Nadolski, alum of my podcast, a friend. Yeah. He does great work. So
I agree.
You're in good company. So let's dive right in. The substance of this conversation: are men's testosterone levels in massive decline over recent decades? As I've heard what seems like thousands of times on social media. It's almost like you hear things enough and it becomes a truism, but
Absolutely.
Does the evidence actually bear this out?
Yeah, it's frustrating to watch. It's one of those things that reminds me of the saying, something along the lines of like a lie gets around the world 10 times before the truth has a chance to get its pants on, or something something along those lines, right? Because it also fits with a popular kind of cultural narrative, and a lot of people latch on to this idea because maybe something about it feels true to them. Maybe they want it to be true. Maybe they're, warriors in the, never-ending culture war on these sorts of topics. And so there's just a insufficient skepticism around it. I think that if people approach this topic with a bit more rigor, a bit more like scientists trying to disprove their hypothesis, and looked into things with a little bit more of a critical eye, or perhaps even if they looked at it with as critical an eye as they tend to look at other things with, they might find that the story doesn't line up as neatly with what they want to believe as has been purported. There have been data sets over time that have suggested a decline in the average testosterone level in men. I would say about that, though, it has not been precipitous. It has not been nearly as dramatic as is often purported. And when these data are scrutinized much more closely, we start to see a few different problems with them. Some of them have to do with the way that these tests are run. And I'm not necessarily intending to get way down into the weeds on the details of like lab assays and analysis and lab interpretation, but test methods matter for the accuracy of the data that you get. And so if you are comparing data across different time periods where different test assays were run, so like an immunoassay that would have been done further in the past and has more issues with accuracy and reliability and overestimation and things like that, compared with more modern what's called like LC-MS assays and things like that tend to be more accurate and precise and reliable. Comparing those two, you can see the issue if you are trying to glean trends over time from two different methods of measuring things that have differing accuracy. So that's one of those issues. The other is that people, they might observe these trends that are reported, not accounting for those measurement issues. And because it fits in with what their gut tells them about what's going on in the world. They suddenly blame it on, all sorts of things. They blame it on seed oils. They blame it on, social issues and things like that. Whereas instead, when we do a better job controlling for the health status of the population, obesity in general, and visceral body fat in particular, among other metabolic diseases and things like that, that also starts to flatten things out a little bit more in terms of this decline that we observe. More of it, in other words, can be accounted for by those issues with worsening population level health attributable to visceral body fat and things like that. And then lastly, and perhaps most interestingly, is that if you pull the data all the way up to the most recent data sets that we have on this, in the past few years, there's actually been an average population increase in testosterone levels, which I do not have a great explanation for. I have not seen a very clear, compelling case for why people have purported all sorts of things. Is it because more people are on testosterone? I don't think that is likely to fully explain this. Is it related to us starting to bend the curve of obesity and it's actually starting to decrease now? I think that probably
alcohol,
most things,
alcohol consumption
going down. Again, there's just so many variables there. But now I'd be very curious to see, hey, now if we have some data showing that testosterone levels are increasing, I can't wait to see all of these folks who have been, sounding the alarm about this, starting to celebrate how awesome we're doing now that levels are seemingly starting to improve again, and that we're clearly on the right track overall, aren't we?
Are they going to try to take credit? Because you mentioned seed oils, there's obviously plastics. And I've even had this conversation before on episodes, if you go back far enough, because again, I am interested in the data. I'm interested in the evidence. Like, let's go where it's taking us. And even if that sometimes leads on a false trail for a while, I just care about where we get. I'll actually read out a post that'll help frame this. I pull this off of Twitter. I'll even say the name. It's one of these ridiculous accounts, Carnivore Aurelius, and I think a lot of people follow this account. It peddles tons of nonsense. It's like, if I wanted to tank a population's testosterone, here's what I would do: put fluoride in the water, cover everything with pesticides, convince people steak, cholesterol, and saturated fat are poison, plastic everywhere, replace with seed oils, tell them to avoid the sun, put heavy metal in deodorants, polyester clothing and underwear, destroy testosterone producing enzymes in the skin by covering it with toxic shampoos, body washes, and soaps. Do you want to rip that apart?
I mean, I understand where this person is coming from with their perspective of very kind of naturalistic fallacy, sort of views on health. I think the issue is the way that I tend to approach these things, and this is something that Dr. Feigenbaum has also joined me in sometimes framing issues, is starting out with the hypothesis and then seeing what we have out there on the topic rather than kind of starting from your endpoint. So people like this who are making those kind of posts, they're starting from their endpoint where it is assumed that population level testosterone is in the toilet, which we've already established is not exactly the case and has better explanations in multiple other avenues. And then they, have their kind of target of a list of villains that they're targeting without providing, substantial evidence to support it. In my mind, I'm like, I'm actually quite open to the idea that any one of those things or multiple of those things in combination could be impactful on human health. I approach this as, what sometimes some folks have referred to as like a neutral Martian observer of the evidence here. I'm open to the possibility, but here's the way that I would approach it. I would say, if it were true that substance X has this calamitous effect on testosterone levels, then I would expect that when studied and we have a population and say half of them are randomly assigned to be exposed to this thing and the other are either assigned to be exposed to placebo or not, then we should see a substantial difference between the two in the outcome that we care about. In this case, it may be blood testosterone level. In my case, it would be much more like what we'll call a hard outcome of health, be it like more mortality, premature, death, or preventable disease or something like that. But if you wanted to focus on blood levels, that's fine. So if it were in fact true that consuming this particular food, say saturated fat, has a substantial beneficial effect on testosterone levels, which is one of the cases that they're making in that post, then when we take somebody who is consuming a maybe average amount of saturated fat or even a low amount of saturated fat in their diet, let's say less than 10% of calories in adherence with dietary guidelines, if we doubled that and put it up to 20%, per that case, should I expect to see their testosterone level double? Triple? You tell me, what should I expect to see? And then that has been tested, right? in as controlled a way as possible. So meaning we might control for overall calories or the other potential variables at play. When those types of things have been examined, we don't see anywhere near the level of impact or benefit as is purported in that post. Some things you might see actually a very modest impact. So people will say vitamin D is like the key. And there are, in fact, some trials where it's like taking people who are deficient to normal levels may have a very modest effect on increasing levels. If you take somebody's testosterone level from 440 to 470, that is neither a clinically meaningful impact on their blood levels, nor is it likely to make them feel any better or function any better beyond what you might expect from placebo. It's, I would say, non-zero, but it's not exactly the type of thing that lets you make a Twitter post like that to say that this is going to be the key to unlock your health and your vitality and your virility and your gains in the gym and things like that. So again, my perspective is not terribly dogmatic about these things. And as it sounds like you are as well, just very open to like, where does the evidence take us on this? And I really like to approach most of these things of like, if this were the case and I do this study, here's what I would expect to happen. In a large portion of cases, that sort of thing has often been done. And when we look at it, it's like, oh, actually pretty underwhelming results, which doesn't automatically make me take the whole hypothesis and throw it away, because no single study should do that for in most of these types of situations. But what it does is it tempers my confidence in that sort of claim, and it makes it so that I'm less likely to, enthusiastically recommend that intervention as something that's very likely to help somebody.
To my coach listeners, I have a little something of value for you, a $1,500 value seminar for just $19, but let me explain the context first. Endorsing people I know and trust is everything. My friend, Dr. Sean Pastuch, is the founder of Active Life. Sean and I have presented at fitness conferences together, and we share a philosophy on helping coaches serve their clients better and want caring professionals to stay in a fulfilling career they love. Sean and Active Life have something of value for you. If you're a fitness coach who works with clients who have pain and movement limitations, and isn't that almost every client, and you feel like you're guessing at solutions instead of following a system, Active Life's professional biomechanics assessment workshop will be of value to you. It's a 2-day live online workshop where you'll learn the foundational principles behind assessment, load management, and how to actually help clients move and feel better. This used to be a $1,500 seminar that people would fly in to attend. Right now, it's just $19. And for listeners of the show, the CEU upgrade worth $100 is completely free. Just use the code COATS at checkout. Go to the link in the description to grab your spot. Again, use the code COATS at checkout. I'm going to sort of tease through the list, and there'll be a few things. And I'm curious to see if any of that list, and I'm going to paraphrase you more or less, that presentation is part of a narrative. And there's a socio-ideological narrative. There is a narrative around nutrition and lifestyle and all this sort of stuff. And there's a status building that's inherent with these type of talking heads. Now, within all these, I mean, I think part of it's misrepresenting the poison is in the dose, right? Like, mention of cover everything in pesticides. I mean, that one gets people really twisted up. But I mean, if you're literally drinking a whole bunch of pesticide, or like immersed in it, working in an environment where you are just coated in the stuff, then there's probably some potential negative health outcomes coming from that. What else on that list? I suspect there's probably some issues with microplastics and exposure over time. I think that's good. Let's do the sun. So avoiding the sun, and you mentioned vitamin D. If you take someone who is never out in the sun and all of a sudden they go out and spend a lot of time without sunscreen, like me, redhead, right? I'm probably going to burn, and then we're probably going to end up over the long term increasing the risk of skin cancer. But it also makes sense that if someone's never in the sun, graduated exposure is probably not bad for them. I'm not saying that someone should avoid sunscreen. So there's always nuance in these things.
Yeah.
So here's maybe the best question. Within that list, is there anything on there that you're like, okay, this particular thing, yes, it's wise that people limit their exposure, are cautious with this. And there actually is, because there's two things. There's the longevity health outcome, and then there's the levels of testosterone. And I think we could look at the cholesterol and the saturated fat one. Let's say hypothetically that someone who ate more saturated fat and consumed more dietary cholesterol to the point where it increased LDL cholesterol, that those levels went up. Those are actually negatively associated with quality of life and longevity. So even if hypothetically, which I don't know if there's any data to say, hey, this boosts testosterone, we actually
Hmm.
have negative health outcomes. So
Hmm.
do you want to unpack that and anything on this list? You're like, hey, this is actually, there is some data to suggest it affects testosterone.
Yeah, that was a lengthy list, so we may have to go through them one by one. I think the
Sure.
overarching theme here that I would convey is that in general, and this is part of the case that Dr. Feigenbaum and I try to make, is that for most people, their blood testosterone levels are more often a better reflector of their health than they are kind of things that than the converse. And so the healthier we are able to get in general, so having a generally healthy dietary pattern, having a healthy body composition, having regular physical activity. To your point, I think that some exposure to sunlight, totally fine with that. I think that there are probably numerous both known and unknown benefits and mechanisms of benefit from regular exposure to sunlight, from the circadian chronobiology standpoint to like probably mood impacts and all sorts of other things. So in general, the healthier we are able to get folks, we tend to see improvements in their blood testosterone levels. So if you want to like rapid fire through those, let's go for it. What was the top of the list?
So fluoride.
I'm not aware of any compelling evidence that that routine concentrations of fluoride that are used in the water for dental caries protection have a clinically meaningful negative impact on blood testosterone levels in the population.
Pesticide.
To your point, dose is the poison there. I think that if you're drinking pesticides, you will probably have a bigger problem than your blood testosterone levels because it may kill you as well. So I think that, to the extent that people are at home cooking their own food, preparing their own food, using healthy hygiene practices, washing their produce when they totally fine. I think beyond that people don't really need to get too much more concerned about that topic.
And it's probably tricky to quantify just how much. So steak is a metaphor for red meat in this particular case. Dietary cholesterol, I will assume, not blood,
Yeah, yeah,
and saturated fat. And
sure.
again, it's the language is convinced that people that all these things are poison, which of
Yeah.
course is a socio-ideological narrative.
100%. Yes. No one has actually suggested that those things are poison. I think that we have reasonable amounts of evidence, multiple different converging lines of evidence, I will say, that for people who habitually consume very high levels of those foods, that substituting those with, health promoting alternatives can generally tend to lower population level risk. I think that you notice a lot of like key phrasing, deliberate phrasing of that sentence, right? Because that's as far as I can go with the conclusion. I can't sit with a person in front of me and say, for you in particular, I am extremely confident that going from this many servings to this many servings is going to definitely prevent a heart attack by age X. But when we observe these sorts of interventions done on, large randomized trials, on like metabolic ward studies, on cardiovascular risk markers, on prospective cohort studies in nutrition studies, things like that, we do tend to see, for example, taking populations who are habitually consuming dietary saturated fat from animal-derived sources in excess of, say, 20% of calories, taking that down closer to 10% of calories, consistently confers benefit, right? The studies that people tend to cite and hang their hats on where they say, oh, high versus low saturated fat intake doesn't really make a difference. Those are folks who are either unaware of what is high and what is low in those studies or are obscuring what is high and what is low. Oftentimes in those studies, there is an insufficient contrast in exposure to be able to identify that difference. So I deliberately said for populations, for example, in excess of 20%, say taking them down to 10%, we see improvements in health and risk factors and in actual outcomes, including cardiovascular events and things like that. Whereas, for example, going from 16% to 14% of calories, you're not going to see a meaningful impact. Now, for somebody who feels they are consuming an otherwise pristine, we'll call it a whole foods diet, plenty of vegetables and say fruits, and they're consuming like lean, red meats and things like that as a decent chunk of their diet, and overall maybe they're consuming plenty of plant-derived nutrients and fiber and things like that alongside it. I think they're going probably a long way to mitigating the health risks associated with their high intake of, say, red meat. Can I make a case that still maybe substituting a portion or two per week for salmon instead is likely to have some beneficial impact on their health? I think I can make a reasonable case for that. Whether that fits the person's preferences, whether that fits their, what they feel is their food preparation skills, whether that fits their, as you said, their socio-ideological narrative, maybe not. And so I don't go to war to fight that battle with every patient if they're uninterested in it. But if they're like, look, here's my dietary pattern, What sorts of areas are there for improvement? What sorts of substitutions can I make? And I'm having, numerous servings of ribeye a week, and I'm like, hey, can we sub one of those out for some salmon, or if I can even get you to try something maybe a little bit further outside your comfort zone, like a legume or something like that. Try a lentil once in a while. If they're willing to try something like that, then I feel that there is sufficient evidence to justify those sorts of substitutions. But I take these all on a case by case basis, depending on what the patient's willing to do.
I have an episode with Dr. Matthew Nagra
Mm-hmm.
on dispelling a lot of the myths about the superiority of animal-based protein versus plant. He's a subject matter expert. It's fantastic.
Yes.
If anybody's interested in a deep dive on that topic, DM me. I will send it to you personally. He's very good. I'll get him back.
Yes, I co-sign his content on that topic for sure. Yeah.
Amazing. Oh, plastics everywhere. And again, that's one of these hard to quantify things.
Yeah, it's just such an early, immature science at this point. I remain very open to the possibility that there are some detrimental effects from this kind of thing. I have yet to see super compelling evidence that would help me to quantify, view it from a toxicological lens. In the world of toxicology, we want to know, what is the substance? What is the mediating, we'll call it almost like a pathogen. What is the thing that is really driving? Because plastics are made up of a whole bunch of different things. There are different forms, right? What is the specific substance that is the most harmful? What is the dose effect? What is the specific toxicity? And what is reasonable to try to do to try to limit that? I think that one of the issues that a lot of people run into these days is, plastics are unfortunately kind of everywhere. And you have to go out of your way to try to avoid it in every possible scenario. And I'm not actually convinced that that's realistic for a lot of people. If somebody feels that they are very concerned about this, very highly motivated to try to reduce their exposure, I don't see a downside to that, for example, in contrast to the prior scenario where they're like, I'm going to double my fatty red meat intake. I'm like, there's actually more of a downside to that I could make a case for. So the plastics thing, it's more like, how much energy and interest are you willing to do to this for an unknown potential benefit? At this point, I really am interested in seeing more data. Now, do I try not to eat plastic? Yes, I try not to prepare my food on plastic cutting boards. There's some, really modest sorts of things. How confident am I that that's the key between my blood testosterone level being, 5% lower or higher? Not terribly high, but yeah, I'm kind of open to that, but it's an evolving field for sure.
I'll interrupt this episode for a quick but important side quest. While I don't think everybody needs to track nutrition all the time, tracking is one of the most powerful tools to make sure you're not eating too much or too little. And MacrosFirst is my go-to app for me and my clients. MacrosFirst has a free barcode scanner, and a premium version comes with a bunch of cool stuff to make managing your nutrition easier. Like, one, AI search. AI is everywhere now, where you can speak or type the foods you wish to save and log everything without having to search for each individual ingredient. Two, import recipes from a website. Save time creating recipes manually by importing all ingredients and instructions from your favorite recipe websites. No more searching for each ingredient one by one, just paste in the website. And three, and this one's a big one for nutrition coaches, follow unlimited friends so you can follow all your clients. And there's a lot more cool features. You can try the premium version of MacrosFirst free for 14 days. Just download MacrosFirst from the App Store. And during setup, you'll be asked, how did you hear about us? Type in the code Andrew. Seed oils. And there's certain ones on here. I mean, the fluoride one, we know that is socio-ideological. That is why I don't think those things have great, a lot of evidence to say that they're as polarizing as the social-political talking heads will grab onto these things and make them about their narrative. Seed oils is the other one. There's so much ideology that overrides evidence.
Yeah, I have honestly started to just bow out of these conversations more often, at least on the internet. The arguments are really, I have yet to see, very productive exchanges happening, unsurprisingly, on social media on this topic, because you'll have some folks who are convinced no matter what, these things are toxic, poison. They're convinced by arguments like, look how they're processed, therefore they're bad. And those are the types of folks who I often like to revert back to one of my favorite books. I feel like I cite this almost every opportunity, How Minds Change by David McCraney. All about the topic of belief change. And it's really, really practically useful, and I think has heavily informed my approach to these types of conversations. Because at the outset, one of the strategies that they often describe, this has been kind of done in research contexts and in some practical and political contexts, canvassing for political candidates, things like that, getting people's sense of what is their position on a topic, How confident are they in that position, say on a scale of 0 to 100? Why did they pick that number? Why not higher? Why not lower? And what sort of evidence would make them move that needle? What sort of evidence would it take for them to move their confidence? Say somebody claims that they're 90% confident that seed oils are super toxic, crash your testosterone, cause cancer, kill you, things like that. What sort of evidence would it take to move that confidence from 90% to 50%? To 40%. You can imagine how this conversation would go. A lot of these folks would say, nothing. I'm already convinced. In which case, honestly, that's where I bow out. I'm like, we don't really have any room to maneuver here. There's not a point to this conversation. For folks who are potentially open, malleable in that way, I am curious, what sort of evidence would it take? Because I am happy to state, here is the type of evidence that I put value on. Here's the type of evidence that would change my opinion on this. Because what I view now is evidence in randomized trials, metabolic ward studies, prospective cohort studies, things like that, looking at seed oil intake or linoleic acid intake as assayed by tissue biomarkers of linoleic acid intake, for example. And if it were true that these things were as toxic as we claim, that they cause cancer, that they cause death, then with higher exposures in these studies, we would reliably see much worse health outcomes. We would see higher risk of cardiovascular disease, more heart attacks, more premature death, more cancer, things like that. Those data exist. When we see these sorts of studies, when we see tissue biomarker studies of those who have been consistently exposed to higher levels of things like linoleic acid over time to lower, the predictions that you had don't necessarily pan out, and these people have lower cardiovascular risk. How do we reconcile that? Your options are to say, well, that challenges my hypothesis, my preconceived idea. Maybe I should shift my confidence in that idea. Maybe I don't rule it out, but maybe I weaken my confidence and I don't go out on the internet making, claims about how this is killing everybody. Maybe I remain open, but it's weakened. The alternative is you flip the table over and you say, this is nonsense research. I still stick with my prior belief. And those are the types of people where it's really difficult to engage with. So again, in these types of research contexts, when people are exposed to higher versus lower, do we see that people's testosterone levels are dropped by 50% or some catastrophic level? Do we see a higher incidence of clinical hypogonadism? Do we know that significant clinical testosterone deficiency, for example, is associated with it leads to a higher cardiovascular risk? So you could say that maybe that's your causal chain. Maybe if somebody increases their intake and it drops that and it leads to more heart attacks. Oh, wait. When we see people consuming higher amounts of these in their habitual dietary intake compared with lower, cardiovascular risk tends to go down. So multiple different ways of coming at this problem don't seem to pan out with there being very clear, compelling harm when you look at what I alluded to earlier as hard outcomes, real things that people care about, not things that they can't feel, like a certain blood level of some intermediate a metabolite, but rather the actual outcome. Are there more heart attacks or fewer? Do they die earlier or not? Do they develop cancer or not? Those are the types of things that, as a clinician, I care about the most, because those are the things that really most meaningfully impact patients' lives. And so I don't really tend to see that adverse effects or harm coming from consumption of these things. At the same time, I'm not going out of my way to drink seed oils in my day-to-day life. I just don't sweat it if there's a bit of it in one of my food items, or if there's a little bit in some salad dressing or in some, packaged product or something like that I might be eating as a convenience food from time to time, not as part of my habitual diet. But the point of demonizing them as part of that socio-ideological sort of project, and then also to the point of going out of your way to avoid every single drop of these things in your diet, I think it's just having way less of an impact and causing way more neurosis than it's worth for the ultimate hard outcomes that we do care about.
And I suspect if somebody's consuming an astonishing amount of this stuff, the calorie load is probably the bigger issue to begin with.
100%. Yeah, no doubt. No doubt. And even then, when there have been randomized trials matching, for example, for calorie intake between polyunsaturated fat intake versus saturated fat intake, say somebody is consuming a calorie surplus, and because they've done this in these research studies, but the calorie surplus is coming either from polyunsaturated versus saturated fats. The saturated fat calorie surplus situation leads to a greater degree of insulin resistance and a greater degree of liver fat deposition, compared with a attenuated effect from polyunsaturated fats. Now, when you're at maintenance, the benefit tilts further in the world of polyunsaturated fats. When you're in a calorie deficit, it's good all around, and so you don't tend to see as much of a problem or of a difference, because hey, fat loss is good for people who are carrying excess body fat in general.
Tell them to avoid the sun. And I'm assuming that there's probably a very strong correlation with the people who are seeing less sun are probably less physically active, more sedentary, probably eating higher calorie diets anyway. But is there anything within that that has any evidence to support a relationship with testosterone?
My best guess I would not be surprised if there is some relationship, but I would just kind of channel it through the lens of like multifactorial general health, right? Because there's probably like some degree of bidirectionality there too, to your point of like, what if somebody has crippling depression? Yeah, less likely to go outside, less likely to get sun. Also, maybe they have some, hormonal metabolic derangements and things like that as well. I am just not seeing people out there advising that nobody ever get any sunlight. Like again, that's taking like staking out the most catastrophic position. No, who is actually recommending this to people? There is a reasonable caution to be had, particularly, for example, in Australia, where rates of skin cancer historically have been like exceptionally high, rates of melanoma, all sorts of things, very, very high. And so it's understandable to want to take precautions around that. That doesn't mean that you should never see the sun. I think that getting sunlight, generally a healthful thing. I think that taking reasonable precautions is a reasonable thing to do, but proxying it as a state of general health. You are waking up at you're following a relatively normal circadian rhythm. You're waking up at a relatively normal time. You have the energy to get up and go outside and do things. All of these things have so many kind of like built-in proxies for your health to be able to do those things, that being healthier in general is also clearly and consistently associated with higher blood testosterone levels. The idea that I, for example, am going to take somebody clinically that I diagnose with hypogonadism or testosterone deficiency and say, oh, just go outside, and that's going to provide a meaningful impact. It might be the case that maybe I treat them for their testosterone deficiency and get that improved, and suddenly now they have the energy to go outside. And it's like, it could just as easily be that direction as well. I'm not here telling people they should never see the sun. I'm not here promising it as a miracle cure. I think it's great for people to go outside, get away from your screen, do things, engage with people, play sports. That's fantastic. But I'm not just seeing the counter that they're staking out here, where it's like they are telling you to like never see the sun. Nobody's really saying that.
And a point you made a couple times is like this is all a straw man argument made to paint this us versus them
Mhm.
tribal. There's this nefarious, evil cabal of scientists that can't be trusted, more or less. What about the heavy metals in deodorant? Is there any evidence to support that there's issues with deodorant?
That I will readily admit, not my expertise. I think that, yeah, there's all sorts of different formulations of these things, and I cannot speak to the details. I similarly think that, as with most toxicology, the point you made earlier, it's going to be a dosage thing. And so, to the extent that there are clear dosage data indicating that with the expected dose that you might be exposed to by using, say, deodorant that contains whatever, aluminum, let's say, that is likely to have a clinically significant impact on an important health marker, I will happily say, hey, I would suggest using an alternative. But that's not something that I'm aware of being clearly shown.
Don't eat deodorant. Got it. Polyester exposure in clothing.
Trivial, honestly. And the other thing that this kind of ties into the bigger picture is we are picking at such minute things in people's day-to-day life while skipping over the much more important things. So somebody might be going out of their way to avoid some degree of plastic exposure or wear a different type of underwear while they are not training enough, or while they are
Mm.
sleeping, 5.5 hours a night, or even having like, any amount of alcohol is likely to outweigh the effect of wearing underwear that is made of a particular substance. So that's the other source of frustration here, is like, even if you wanted to be a real like optimizer in this space, there are still far bigger like, rocks that you could work on compared with what kind of underwear you're wearing.
Let's go into that because that's something I had planned. We just kind of went to the end early, but it
Yeah,
worked out
yeah.
really well. In particular, alcohol, obesity, degree of adiposity, and then perhaps are there any major environmental pollutants that are actually of concern based on the data? And how much do each of these affect testosterone levels and more broadly health?
Yeah, super big. I mean, this is essentially part of the project of the entire book. So a lot to get into here. I think that I would start with the biggest and the most important one that we deal with in practice day to day. So I see, patients as part of my practice, both inpatients and outpatients, and I think that a few common features emerge when I tend to see low blood testosterone levels, in particular with concern for clinical testosterone deficiency or hypogonadism. And those relate to the broad set of obesity and cardiometabolic diseases kind of in conjunction. So that's excess visceral body fat, type 2 diabetes, prediabetes, insulin resistant spectrum, things like cardiovascular disease, chronic kidney disease and fatty liver disease. That's kind of like the spectrum that we're talking about. Those things ultimately, as a result of numerous converging pathways of our modern lifestyle and insufficient physical activity and excess energy intake over time and things like that, compounded by poor sleep and lots of other things. So I would say that by and large, that is the most common reason that I end up seeing these issues emerge. The other thing that's important to point out is that the symptoms that, and I'm sure we'll get into this too, the symptoms that people experience with hypogonadism testosterone deficiency can in many cases be what we call non-specific. You've heard, for example, a symptom like fatigue. Lots of things can cause fatigue. Now, testosterone deficiency can contribute to fatigue, but so can, for example, anemia. So can sleep apnea, just to name a few. So can thyroid dysfunction. So can, just poor sleep quality in general, even if you don't have sleep apnea. Lots of different things. But at the same time, a lot of these things also co-occur with one another. So obesity increases the risk of sleep apnea, which also increases the risk of hypogonadism. So it's tough to tease. The point I'm making is it's tough to tease apart exactly how much or any one of these contributing when so many of them are co-occurring and comorbid with one another and almost feed into one another, right? So for example, somebody develops obesity, then develops sleep apnea. Their impaired sleep quality increases their appetite and lowers their energy. They tend to eat more and move around less. And that perpetuates the cycle of obesity, which then worsens their metabolic function, which worsens their testosterone levels, which then cycles back into energy levels and sleep and all sorts of other things all over again. So it's quite complex how these things all tie into one another. But we do see very regularly that obesity is a common underlying driver of testosterone deficiency and hypogonadism. And the converse, this is how we know it's causal. The converse is also true. When people lose body fat, whether through routine diet and exercise, through the use of GLP-1 agonists and other anti-obesity medicines, through the use of metabolic bariatric surgery, testosterone levels tend to improve, sometimes quite markedly, sometimes a little bit less so, but pretty consistently, we tend to see improvements. So those sorts of obesity and obesity-associated chronic diseases are by far among the most common. Acute illnesses now can also impact testosterone level. And so this is why, for example, I'm not routinely checking testosterone levels among patients that I see in the hospital. I admit you for sepsis from some bacterial infection or the flu, or you just had a heart attack. Now is not the time to be checking that level because these things all tend to go down in the setting of acute illness. So this ties into when is the right time to test? How should we go about testing and interpretation? Alcohol, to your point, is one that can be very problematic across numerous organ systems. And this is another one where I'm going to be hesitant to tie it into a single particular pathway of alcohol being directly toxic to the testes, because that is to some extent true. The dose also matters. Is it like a more of a binge alcohol type behavior, or is it a chronic, low level alcohol type behavior? And then how is that impacting the rest of your health? Because you can have alcohol associated mood disorders, for example, that can precipitate depression, which can then impact your activity, which can then impact your sleep, which can impact. So again, coming back to this idea that all of these variables are kind of interrelated, often comorbid, which is why taking a history on these patients, getting a sense of what does their overall lifestyle look like, assessing their weight, their activity levels, their sleep, their diet, their alcohol use, other medical conditions that have been diagnosed, screening for appropriate medical conditions when needed is a big part of the evaluation. So definitely the obesity piece, the alcohol piece, sleep is the next one that I think is worth touching on. Both sleep restriction, acutely or chronically, or even if you have sufficient, like we'll call it hours of sleep in bed, but poor sleep quality over time, which can be related to, all sorts of what we call parasomnias or sleep-related disorders, sleep-related breathing disorders, obstructive sleep apnea. All of those things can also contribute to worsening of people's testosterone levels. There have been some really interesting studies done, for example, in people, sometimes in like military recruits that are like acutely sleep restricted when they go through some rough basic training course or something. And then over the course of like 5 nights of sleep restriction, their levels are like cut in half. Now, that is a response to that sleep restriction. And when they are allowed to do what they need to do, levels tend to rebound. And I mention this both because it's an interesting sort of finding in the research and also of relevance with the current sort of military posture towards testosterone and evaluation in their soldiers, which just came up within the past few weeks. So we've touched on the obesity piece. We've touched on the alcohol piece and sleep. Other ones that I think are touted as having huge effects, but maybe actually a little bit less than people think. When it comes to nutrition, dietary quality can certainly have an impact on people's health, but specifically manipulating certain like nutrients or macronutrients in the diet and things like that, including dietary cholesterol, dietary fat, dietary protein, dietary carbs, outside of extremes, tends to actually have a pretty modest, if any, effect. At least when this has been researched actually quite thoroughly. Where people consume higher versus lower amounts of dietary fat, protein, and carbs in their diet, and relatively unimpressive sort of effects, again, outside of extremes. When people go extremely low carbohydrate intake, that tends to lower blood testosterone levels. When people, interestingly, go extremely high protein intake, like in excess of I can't remember the exact figure, 4 grams per kilo, like really, really high amounts, that also, unsurprisingly, is like not great for people's health to go to that level of an extreme. Manipulating fat, whether the type, saturated, unsaturated, things like that, and also the amount, modestly lower versus modestly higher, again, outside of extremes, kind of unimpressive effects. And the reason I lay it out this way is to try to illustrate when I'm working with a patient and we're working up through the things that can be done on the lifestyle front before we get to consideration of testosterone therapy, for example. What are the levers that are more powerful and like worth pulling versus what are the things that are not worth worrying as much about? It is worth worrying about the obesity piece. It is worth worrying about the sleep and the alcohol. Whether you choose to consume a slightly lower fat or higher carb or lower carb, higher fat diet is not something I'm going to get terribly excited about if it is within the general parameters of the dietary pattern we're looking for to facilitate your weight management, right? Similarly, or I guess in the same vein, how much plastic you might be exposed to in any given day. Not one of the first or second or third or fourth or fifth levers I'm likely to pull when I'm working with a patient because they only have, so much time and energy and resources to deal with this in any given day. Like I practice in the real world, not on Twitter, where patients have, jobs, families, kids, they have responsibilities. They're just trying to do their best. They're trying to be kind of healthy. And so pulling the levers with the biggest impact is where I would put way more of my energy. And while telling them that, you need to follow this precise, maybe I'll spare the specific podcaster's name, but they're like, list of protocols that you need to do. The first thing you wake up in the morning and do all these things, and then worry about what kind of underwear, your fabric you're wearing and how much plastic you might be exposed. You're going to lose a lot of people at that point. If somebody wants to go down that hardcore optimization rabbit hole thinking it's helping them, like I'm not really going to argue with them if the other pieces are already in place. But if they're doing that and I'm like, yeah, and then I like to go out and have a few cocktails on weekends, I'm like, okay, like I think we're stepping over the bigger rocks to pick up the smaller ones here.
Quick side note, because this conversation is prefaced around testosterone.
Yeah.
I want to go back to this later about the actual relationship with it, the relevance to women. I think most of this conversation has been around things that are also very relevant to general health. So I still think it's very relevant to women, broad scale. We'll circle back, but I did want to prompt that there just so that way it's not lost in all this. But the next question I wanted to ask was, does low testosterone directly cause specific issues? Or is a lot of this stuff comorbid with the other things that are the problems?
Yeah. I wish there was a super neat, tidy answer to this. I was thinking about, in anticipation of our conversation, how I wanted to frame certain topics. And one thing that I think that is really underappreciated by the general public, by patients when they're seeing doctors, even by some doctors, is that medicine is very probabilistic. It is messy, right? And so here's kind of the way that I'm going to frame this is, let's say that somebody's blood testosterone level, you have a guy and his blood testosterone level is 600. What is the likelihood that he has insufficient testicular function or hypogonadism or testosterone deficiency? Exceedingly low, right? What if it's 500? Very, very low likelihood. What if it's 400? Still pretty low. What if it's 300? Now we're starting to get a little more suspicious. What if it's 200? Much more suspicious. What if it's 100? Very, very likely. What if it's 5? Definitively, right? This is a spectrum, right? The problem with labs and the way they are done, the way they are performed, the way they are reported is they have binary cutoffs. This is what you see when you get your lab tests back. It says it's normal or it's high. Nothing in biology is quite so neatly dichotomous of it's either low or it's high. So when I'm assessing a patient, I'm not just looking at their blood level. I'm trying to get a sense from what they are experiencing to inform the probability that they could have this, and then using the subsequent data that I collect to further support that hypothesis, strengthen it, or to weaken it. Why am I doing that? Because that is what then informs me how likely is this person to respond if I was to try treating them. That is ultimately what I'm trying to get a sense of here. So that's why I don't like applying very rigid cutoffs. And I don't make overly confident claims about, this definitively caused this problem or it didn't. Rather, what's the probability that it caused it? And more importantly, for you probably as the patient, what's the probability that treating this means it's likely to get better? That's kind of the path I'm trying to walk with a patient through in this conversation. So to that end, there are a whole variety of symptoms that have been associated with low testosterone levels and that you'll hear people report in the context of low testosterone levels. In the book and in the course that we created, I broke it down into signs that are more specific. An example of a more specific sign is a man, for example, who underwent normal sexual development, normal puberty, had normal libido as an adult, and then subsequently lost that libido, like it went to zero from a previously normal level. That's a symptom that's actually on the more specific side. So specific meaning like it's pretty suggestive, right, that you could have an issue with testosterone. Now, on the other end of the spectrum, we have something like brain fog or fatigue. I mentioned that earlier. Could that be compatible with a diagnosis of testosterone deficiency or hypogonadism? It's possible. Is it very, very specific for it? No, because you and I, we have both felt that after a night of poor sleep. You might feel brain fog after a hard deadlift set. You might have felt it if you were hungover. You might have felt it if you had anemia or thyroid issues or sleep apnea or any number of things.
Context. Longtime listeners would know that I had battled brain fog post-COVID, late 2020, intermittently over the course of a couple of years. Also, I've talked about this, I've mentioned a while, but I was diagnosed with Hashimoto's with several months ago. Runs in one side of the family, so low thyroid, and that's being managed by thyroid medication. And so I wonder if there was a relationship between all that stuff, right? But one of my first thoughts was I wasn't concerned that I had low testosterone.
Precisely. And it's not to say you couldn't have had it, but rather that when you have a less specific symptom, the probability that it is due to low testosterone is less, which also means that the likelihood that you would have gotten better with testosterone replacement would have been low. If somebody, that's one of the issues is that in the fitness space, particularly that with the testosterone slant, the very male-oriented testosterone optimizer space, everything is due to testosterone deficiency. Everything is going to get better if you put man on testosterone. You see these absurd testosterone. If your level's not above 1,000, then it's low or something like that. And it's like, yeah, you can say that since you're not a doctor with no responsibility to patients, right? As soon as you are actually faced with responsibility to patients, with the liability of I could miss something really bad here, right? And I could be mistreating them. Then a lot of times your perspective might change. One of the more egregious examples of this that I saw in the past was a guy in his 40s who, again, had this sense of fatigue, some brain fog, had been assessed for testosterone and was getting ready to start and wanted another opinion on this. And I was like, your workup has not been anywhere near sufficiently comprehensive. We need to look at a lot of other things. I found him to be significantly anemic due to iron deficiency. And in somebody, a man of that age, iron deficiency is basically colon cancer until proven otherwise. Like you need to get a colonoscopy. We need to find the source of blood loss. In his case, fortunately, he did not have colon cancer, but that was the risk that somebody was taking by just saying, oh, your brain fog is from testosterone. You need to get put on this. He had iron deficiency for other reasons that also needed to be treated on their own, right? Which I'll leave those details out in that particular case. But that's the kind of thing where it's like, if somebody says, look, I've got the fatigue, I've got the brain fog, I've been having a really tough time in the gym, I've got, a bit of body fat accumulating. I used to have this awesome, libido was great. Everything was going well, excellent erectile function. All that stuff has gone away. I'm losing body hair, things like that. I'm like, okay, now with every single thing that this person said, my probability that testosterone could be an issue is actually increasing. I'm like, okay, more suspicious. Now what do? I'll do the proper testing to confirm, as well as some of those other things to rule other issues out. And now if that further supports my hypothesis, I'm like, okay, now I'm very confident in this diagnosis, which also means that I'm quite confident that treating you is likely to benefit your symptoms. But it takes doing that hard work up front before I can say that. That's the challenge, and that's the difference, I think, between having the clinical responsibility to a patient versus being able to tweet whatever you want on the internet.
This episode is brought to you by Just Bite Me Meals. I work long days and I won't compromise my client experience or sacrifice my workout, sleep, or nutrition. So I needed a quality and reliable meal prep service so I could save time on cooking and shopping and have more time for the stuff that matters. Net out the cost of groceries, and the service isn't as much as you might think, and regular impulsive food delivery apps eating out that costs way more anyway. I get more meal variety and less dishes to clean, and I've been referring clients to Just Bite Me meals for a long time, and I recently started ordering myself. Food is great. The beef brisket tacos are my favorite so far, and there's a lot of menu choice. Your calories and macros are listed. The portions are great. You can order custom meals. They deliver to your door, or you can pick up from their storefront. And I'm sorry to listeners outside of Alberta, but Just Bite Me Meals is currently just in Edmonton, Calgary, Grand Prairie, and Fort McMurray. Ordering from Just Bite Me Meals made my life easier instantly. And you can get 10% off on all your orders using my code, Andrew Coates Fitness, all caps, on their website. That's Andrew Coates Fitness, all capitals, or go to the link and the code in the show notes. You said something earlier, and it was something I plan to go into because it's really important. I'll frame it this way. I grew up in an environment lifting in gyms, bodybuilding-esque culture, and we certainly thought and heard that, well, when you lift, you have to do the big compound exercises because it will elevate your testosterone, growth hormone, and we had these transient increases, which you can see in these hormones, these anabolic hormones. Related to this would probably be, having carbs post-workout. And I used to say this stuff early in my career would spike your insulin, therefore that's anabolic. But as I understand it now, that transient fluctuations within normal physiological ranges of any of these anabolic hormones do not seem to have any impact on, well, muscle hypertrophy for one, or I'm not even convinced any health related stuff in general. Can you speak to that?
Yeah, totally. This is another example where I think that the modern space, like I love that people love science and they love nerding out about the mechanisms and the physiology and things like that. But it is possible to go so far down that rabbit hole that you end up in like the land of minutia, and then you end up in the land of minutia that really don't matter. And the problem is that it's possible to craft a very compelling narrative out of these things to support whatever your training theory is, whether you prefer high intensity training or high volume training, or whether you prefer, endurance training or strength training or power training, or whatever your dietary approach is and things like that. So this is where numerous fitness brands and personalities have emerged from with their unique approach that's often based on some sort of, maybe grain of mechanistic truth, even if that does not pan out in reality. So it is a nice, neat, tidy, seemingly, plausible narrative of you do this big movement, it jacks up your testosterone, you get bigger and stronger. So really that's what we should be chasing, is the type of training program that maximizes those responses. And it's like, sure, that sounds fine. But the results that you might be getting from strength and hypertrophy and all these other kind of things, yeah, you should do those exercises if you like them to get those outcomes. They work for that, no doubt. Like, big fan of squatting and deadlifting here, been doing it for a really long time. I have never once thought about what was my acute post-exercise testosterone response, what was my acute post-exercise cortisol response, what was my acute post-exercise growth hormone and IGF-1 response. If I was injecting some of those things, I might be thinking about it a little bit differently. But those short-term fluctuations post-exercise is just the very elegantly orchestrated systemic response to the training stress, and it just proceeds on its own. But it's not something that you need to optimize for. Rather, I would optimize for the actual outcome. Like, am I getting stronger? Am I building more muscle? Rather than worrying about what specifically tends to impact these hormones the most, because now it's been probably approaching the better part of a decade since this stuff has been refuted, or if not more than that, and we're still see people talking about it on the internet.
It just made me think of Jordan Feigenbaum and, I mean, him racing with his Viper and all that stuff you see as media. That's probably got to cause some pretty acute increases in testosterone. I don't know how anabolic it is. Yeah. So
Yeah, I mean, it's also probably terrifying. I mean, he's probably driving the whole time with a heart rate of like 180, and I suspect his cortisol is also high. And what's happening? He's not coming to the gym the next week and losing all of his gains and unable to deadlift 500 or 600 or whatever.
Well, that's another point is cortisol, theoretically, in the right context, a catabolic hormone. Again, the transient increases we see in response to exercise does not have these acute responses, does not have detrimental effects on muscle hypertrophy or health in general. It's just the chronic things. And I think maybe it's worth qualifying that in super physiological, super normal doses of testosterone, growth hormone, insulin, because we'll see bodybuilders who will literally take insulin post-exercise. These are profoundly anabolic. We know that they work really, really well in super physiological doses.
100% agree. No doubt. Those things all have significant impact, super physiological. It is
And
just
risks.
not. Yes, totally. It's just you cannot then kind of conclude or extrapolate that to a similar gradient of effect across the physiologic spectrum. Because what we tend to see is much less significant impacts of variations within the physiological range. This is another issue that I think is often an artifact of lab tests being a snapshot in time. These hormones are going up and down all the time, whether on some form of circadian diurnal rhythm, pulsatile release, things like that. And you check a blood test at one moment in time and then you draw a conclusion off of it. Generally not the most wise sort of thing to do. Similarly, same thing with cortisol. Outside of physiologic ranges, if somebody has clinical Cushing's syndrome or disease, yes, they are very unlikely to have very large amounts of muscle mass. They're likely to have, osteoporosis and excess amounts of body fat. And then outside of the physiological range on the low end, somebody has adrenal insufficiency. That is a medical emergency. You can die if your cortisol is too low in an inappropriate situation, as I have seen and diagnosed in the hospital. But if you were listening to some folks on the internet, you might say, gosh, I never want my cortisol to go up. I need it to be nice and low all the time, which would be not ideal and not bode well for your ability to cope with stressors, physiologic or otherwise.
And you said it in there, but I really want to double down on this. Someone who, if they get a testosterone test and it comes in at what we consider to be within the lower ends of the normal physiological ranges, they should not be concerned, and it should not have any negative impact on their ability to build muscle or their health. Is that correct?
Partially. So anytime somebody brings up the question of, I got my blood testosterone level checked, here it is, what do you think? My first response is, before I even look at the number, can you tell me why it was checked? This is getting back to my idea of I need to build my what we call pre-test probability that this level is going to be meaningful, because tests are imperfect. Pretty much all tests have some rate of false positives, false negatives, analytical variation, biological variation, things like that. So imagine I'm talking to somebody who is, extremely jacked, extremely strong, feeling well, just competed at a meet and has set all-time PRs. And they tell me, I'm really worried about my testosterone level. What is my baseline, my pre-test probability that they're likely to have testosterone deficiency or hypogonadism? It's going to be pretty low. In that case, if their level is at the lower end of the normal range, I am more likely to interpret that as maybe a spurious result of some kind, a false positive result. It might be related to the timing of when they got it done. It might be because they had a big meal before it. It might be because of, poor night of sleep before it, or alcohol use before it, or something like that. Or it might be because they're just coming off a cycle and their levels are going to be low at that point too, right? So that context really matters when I'm interpreting what does a blood level look like. The other interesting thing that has been shown is among men who have these levels checked, and they are, say, around 300, maybe just below 300, if you are to repeat that at a subsequent time point, a substantial fraction of those spontaneously normalize. And that happens for all sorts of reasons. It could be some combination, again, of analytical variation, meaning test variation, error bars in the test, biological variation. These levels go up, go down all the time. Or it could be something that was going on in their life around the time when they got it drawn, that is no longer going on at the subsequent recheck. Maybe they got it done just coming off the tail end of a cold, or they were going into a cold that they really hadn't started to feel, and these levels get a little suppressed when you're sick, and then you're better at the later time point. Any number of things that can impact this. One of the nice tools that I often cite for people, more for illustrated purposes than anything else, it's a tool that was published on the British Medical Journal's website that's called Your Results May Vary. So anybody who's interested, you can just Google Your Results May Vary. And it's a nice tool that lets you select which lab test you are interested in. And you can put in two different values that you've got. And it could be your testosterone, it could be cholesterol, it could be your thyroid hormone level, it could be whatever you want, triglycerides. And you put in those two levels, and it will tell you, based on the known analytical and biological variation inherent in these tests, how likely is it that these are truly different results. Because you'll sometimes see guys who are like, I got my level checked. It was 400. I did this thing. I started doing my morning walks in the sun. I avoided plastics. I changed my underwear. Now my level's 440. And it's like, well, let's put those into this tool, and I can show you how likely are those to be meaningfully both fall within the error bar of one another. And so it's like, statistically, I can't be that confident that that's great. I'm happy for you. But I think that we should, again, temper our confidence in what's happening here, because if you had had that blood level checked half an hour earlier or half an hour later, it could have been the same as it was before. Again, part of the problem with blood testing and people kind of over indexing on this like single number that shows up on a lab report and the binary normal or abnormal. I wish to some extent that labs were reported instead of a single number as like a 95% confidence interval. People would have a lot less hot takes about labs if that's how they were reported, I think.
Another relevant example, I just think about, I had a tough leg day on Saturday. I've been sore for 3 days.
Yeah.
If I'd gone the day after that workout and got my creatinine kinase levels checked with the doctor not having the context, I
Yes.
probably would have been directed to be hospitalized for kidney failure, when in fact I'm pretty adapted to that level of stimulus over time. But again, a snapshot is going to be misleading if taken out of context.
100%. Snapshot and context matter all the time. The other thing is, because I train junior doctors and residents, and so what they tend to see, for example, in the hospital setting, when we're checking, to your point, a CK level, most often it's in a patient where there is a high pretest suspicion that they could have rhabdo. And they're only going to meet somebody like me on the inpatient side if they have rhabdo and need to get admitted, right? So all they ever see with CKs are patients with rhabdo. They're not routinely checking CK levels in people who don't have rhabdo. So when they're faced with somebody who says, I am sore, or I just did this workout, and they check a CK and it's high, they're like, oh my God, it's rhabdo. And I have to tell them, it's like, no, no, no. That single CK level does not define rhabdo, especially in this context where you have somebody who just did an ultra marathon 48 hours ago. Like, the question is, why was this checked? Are we worried that they could have, and because that again informs your interpretation of the test. These numbers, by and large, there are relatively few tests that should be interpreted in isolation in the absence of any clinical context information. Even one of the most dramatic tests that you can do in a medical population, it could be like a blood troponin level, which is like a cardiac biomarker, what we use to diagnose heart attack, or an EKG. When I'm looking at an EKG, when I'm looking at it, I still want to know, hey, what's the context? What did this person come in for? What are the symptoms that they're having? Because that could radically change whether I'm worried that they're having a heart attack or something completely different from a heart attack, because a lot of things can be nonspecific and look like one another. So I can't emphasize enough, and also why people, I'm not super paternalistic, or I try not to be in like the medical realm. I think that people can, people can do whatever they want as long as they're, reasonably informed of, potential risks that they could be engaging in. But direct to consumer laboratory testing, I think causes oftentimes at least as many problems as it helps. Certainly, no doubt, some people are benefited by being able to, get their own tests if they're unable to access them otherwise, or whatever the case is. But trying to interpret their own tests is where the problem comes in, because a lot of these things are reported with a overly simplistic stoplight system, a green light, red light type system for your test. And then they buy all these tests, they get them done. They don't know how to interpret them. And then they consult me like, hey, can I run all these tests by you? And I'm like, why did you get every single test under the sun done? Why did you go to this company? Again, I will leave the company unnamed in this situation, a very popular one. But why did they check your blood leptin levels? There's like literally no reason why you should have that done, nor should you be worried about that kind of thing.
I mentioned earlier the conversation as it relates to women. So, is there any aspect of the testosterone conversation that is specifically relevant to women, or even just fluctuations within their levels, or things women should be concerned about?
Yeah, I try not to raise a ton of alarm, broadly speaking, unnecessarily, to where everyone is going to want to go and get their blood tests done if they don't have a clinical indication for it. I would say if they have specific concerns or specific symptoms, definitely speaking with a clinician that they trust about these things. And there may be a situation where it's worth checking some of those labs. The testosterone piece in women is really interesting, and unfortunately is also, I would say, a very immature science. It's something that we have now a slowly growing body of evidence on. And the main area, I would say, there is currently one very strong evidence-based sort of indication where testosterone can benefit women outside of just, as we said earlier, like straight up PED use in sports. But in the health context, is for improving low libido in postmenopausal women. That is an area where we have sufficient evidence for use. It is not yet fully FDA approved in the US sort of indication, unfortunately, although plenty of people were doing that in a more of an off-label fashion for folks in that particular demographic. In Australia, it's done actually quite a lot more. And that's actually where one of the leading researchers in the world on this particular topic, Professor Sue Davis, is out of Australia. She's done most of the research on this. Testosterone in women in general, mostly in the postmenopausal libido context, but that research is now slowly starting to expand into perimenopausal and premenopausal women. I think it's totally reasonable to use in that postmenopausal context. I think it is also reasonable, although less evidence-based, to use it in the perimenopausal context. I do not think we have great evidence for its use in the premenopausal, definitively premenopausal context for that particular indication. Outside of that, we don't really have a ton of evidence on the use of testosterone therapy for many other indications. You will see, again, lots of anecdote because a lack of evidence leaves space for just off-label prescribing and anecdote and placebo type effects and things like that to emerge. And so my preference is, not to confidently attribute to the therapy what could be plausibly explained by placebo until or unless we have data to show otherwise, right? And so that's where, again, we have pretty good data at this point that the use of that therapy in postmenopausal women to improve low libido outperforms placebo, right? In some other contexts, it might be no better than placebo for the outcome that you're looking at. And so I'm like a little bit less confident. My take, though, is that if something is safe or can be done safely and the patient is fully informed of potential downsides and they want to try something, I'm often very open to working with people almost like in an off-label experimental fashion. If I have, again, good rapport, good trust, and it can be done safely. I really dislike, situations where I hear patients, because I end up, working with them a lot or consulting with them where they're like, I saw my doctor about this concern and I was just like summarily dismissed, or they just rejected this idea out of hand. I'm like, well, I think it's at least probably worth a little bit more of a conversation. What are the potential benefits we're looking for? What are the potential downsides we're looking for? How likely are you to get these benefits? Again, you hear me using a lot of probabilistic terms here, right? Because this is a lot of it is gray. And what are the potential downsides that we should be aware of? If we choose to move forward, what would be a good monitoring plan? What would be the goal of therapy that we're trying to achieve? If we don't achieve it, would we be at a point where we say, okay, we can stop it? And I say all this to also tie into regular old testosterone therapy conversation. Let's say I have a guy whose levels are kind of like in an equivocal range, right? And let's say he also has some equivocal symptoms. Some folks might say you don't have definitively low levels, you don't have definitively clear, obvious, testosterone deficient symptoms. Under no circumstances will you use this. I'm like, but what are you most worried about if you were to try, right? A lot of people might say, well, you're automatically committing to a lifelong of therapy. No, you're not. Like, you can do a time-limited trial of this with a goal in mind of here's the symptom I'm worried about. It can be monitored. It can be done safely, if not otherwise contraindicated, meaning there's not another reason to not do it. And if it improves the target symptom that I'm looking for, then okay. Is that a rigorous, randomized, placebo-controlled clinical trial? Not necessarily, but it is also, if it's being done safely and the person's, health, longevity, quality of life is seemingly being improved, like I'm very open to that. I'm not in a situation where I would recommend or be pushing people's testosterone levels to super therapeutic levels, or somebody who clearly does not have clinical hypogonadism or testosterone deficiency and putting them on therapy. But in these gray areas, I do think there's some room for this kind of, this sort of approach with folks. And I think that they tend to appreciate that quite a bit.
Probably an oversimplistic question, but is TRT overprescribed currently?
Jordan has posed this question to me on our podcast before, and my answer is that I believe it is both overprescribed and underprescribed. And all of that is to say that it is misprescribed more often. There have been several different sorts of study designs looking at this question where, for example, a significant proportion of people who are initiated on testosterone therapy do not have the appropriate lab evaluation before they are started on therapy. A significant portion of people who are started on therapy do not have the appropriate follow-up evaluation after they are put on therapy. So there are many situations, and this is due to the incentives that play in the system. This is due to, hey, if you have a TRT clinic just off the highway, some guy comes in and he's like, I'm tired. You could walk out same day with a prescription. That does not mean it is good medicine, but that is a situation where it is definitively being overprescribed. Excuse me. On the other hand, having gone through internal medicine residency training, being familiar with what that looks like, being very familiar with what family medicine residency training looks like, just primary care type training in general, outside of the most clear-cut, slam dunk, obvious, severe cases of hypogonadism and testosterone deficiency, there is not a great deal of training on how to go about this process, how to manage that therapy, and a great deal of comfort with it. And so you will probably find a fair amount of scenarios where somebody might otherwise be a pretty good candidate, yet it has never even been brought up with them. It has never been discussed with them. So I think that our resources in this space are mostly misdirected. So that is how we end up in a situation where it is both overprescribed to people who probably don't need it, whether they don't need it at all, or whether they don't need, not just they don't need it, but they have another issue that is not being addressed, like my guy with iron deficiency that I mentioned before, for example. or people who are never appropriately tested in the first place. Because, I often teach this to my residents: you never make the diagnosis that you don't think of in the first place, right? You have to be able to think of the diagnosis, to test for it, to look for it, to diagnose it. And so if it's not something that comes to mind for people to look for, they're never going to make the diagnosis, and things get missed. And then they might get treated in other ways. You might catch, some other sort of lab abnormality and say, oh, maybe it's because your TSH is a little bit off, or maybe you need an antidepressant or something like that, which may help some people, but it may not be the right answer for that person. So I like being a generalist in this way, in that I can formulate a very long, sometimes near endless differential diagnosis for a given presenting complaint, and work through it systematically to try to find what is a reasonable, safe path forward for the patient. And sometimes I set expectations that it might be a little bit of a trial and error process. We might have to try something and it might not work, and we might need to go to plan B, plan C, which also just often builds more rapport and confidence that, like, I'm thinking ahead. If this works, great. If it doesn't, we have another plan. Versus if you go to the TRT clinic and they shoot you up with a huge dose of testosterone, and then it doesn't work for you, what's their backup plan? They're like, well, I can't help you. Go someplace else, or take a SERM or something like that instead.
What conditions would you recommend someone get their testosterone checked, and what goes concurrent with that as well?
So there are a lot of conditions that are going to be associated with testosterone deficiency. There are actual clinical guidelines on this from, I believe it's from the Endocrine Society, for lists of conditions where it is reasonable to screen. So I'll give you a few examples. And just to emphasize, it is not the case that just because you are going to look for a condition that you are automatically obligated to put the person on testosterone therapy as a result of it. But there are higher risk scenarios that are often recommended for this. So lots of patients with chronic metabolic and inflammatory diseases, there are guidelines in the Endocrine Society for, like, what they call, rather than broad population-based screening, which means just testing everyone, which is generally not recommended at the moment, but more like what they call targeted kind of case finding. And so patients with advanced kidney disease, advanced COPD, HIV infection, type 2 diabetes, COPD, these are things that are all associated with higher risk. Now, whether you choose to act upon that finding, pursue treatment, that involves a much more detailed and individualized conversation, potential pros, potential cons, risk profile, things like that. Anybody on chronic opioid medicines, because that is well known to increase the risk of testosterone deficiency. So people who are using that for chronic pain purposes. And so there's a handful of these conditions that we outline in the text as well, where it is often worth testing, even if it is not something that immediately comes to mind or comes to the forefront in the clinical encounter. I have come across this being taught essentially nowhere in my own medical training or that of my colleagues, where this particular element of the Endocrine Society guidelines were emphasized in terms of a little bit more targeted kind of case finding in patients who are at higher risk due to their comorbid conditions.
I think that pretty much nails this. I mean, everybody can go and dive in to your media. So your Instagram is at Austin_barbell medicine. You guys have the book coming out, Signal. What's the date of release on that?
It should be at some point within the next month, is my understanding. There's been a little bit of back and forth with some of our editing folks and the publishing team, but I'm expecting it during the month of August of 2026. So anybody who's interested, it will not be subtle when it comes out. We will certainly make it clear to folks. Feel free to check it out, and we're happy to engage on the topic and have hopefully productive conversations with folks who are just as interested in the evidence as we are on it.
I appreciate you coming on. This was absolutely fantastic. As long as you want, you'll be coming back for future episodes. I love the way you communicate this stuff.
Hey, thanks so much. I appreciate the opportunity.